This is week number 8 on healthcare ethics and compliance. The federal 340B discount drug program has been in place for over 20 years. A program established to help organizations serving a disproportionate share of indigent patients with access to medication at a deep discount. The recent 2010 amendment to this program allowed organizations to contract with external retail pharmacies have generated $1 million of revenue for both the hospital and also the external retail pharmacies. There is increasing scrutiny to this program because it was intended to support organizations serving indigent patients and not to be a revenue stream for-profit retail pharmacies. In April of 2010, HRSA, known as Health Resources and Service Administration, issued new guidance allowing covered entities to contract with an unlimited amount of 340B contract pharmacies. The main justification for this change was referenced by many 340B entities that patients currently face transportation barriers, which limits their ability to fill prescriptions and access 340B pricing if they can't travel to a 340B contract pharmacy. However, from 2010 to 2013, the number of contract pharmacy arrangements exceeded HRSA's projection by almost 20,000. According to the 2014 RAND Corporation report by Mulcahy et al., the 340 contract drug discount program, the actual number of contract pharmacies increased from 3,000 to over 12,000 from 2010 to 2013. The U.S. Government Accountability Office report in 2014 provided strong indications that 340B covered entities often fail to adhere to the types of practices intended to ensure the program integrity requirements are met to the contract pharmacy program. Now, looking at the revenue for the for-profit retail pharmacies, unlike traditional dispensing earning spreads, the participating retail pharmacies earn a per prescription fee from the 340B hospital, which is usually at least 5 times the traditional dispensing earnings. According to the Alliance for the Integrity Reform of 340B, 2014, the Impact of Growth in 340B Contract Pharmacy Arrangements report cited the character of the 340 program has changed significantly, mainly by the role of the program of the large for-profit chain pharmacies such as Walgreens. As of mid-2014, 72.4% of the chain's pharmacies participated at least one contract pharmacy network. Those less than 15% of the chain's pharmacies are in zip codes with an average income below 200% of poverty level. In addition, a chain employee stated on his LinkedIn webpage that the 340B is projected to add a minimum of $250 million in incremental revenue over the next 5 years to the chain's revenue. There is much concern here because the intent and design of this program is to help lower patient drug prices for the uninsured. It is not intended to subsidize pharmacies that team up with covered entities to turn a profit. Now, looking at the impact of the hospital and the patients, leveraging the 340B contract pharmacy expansion, a 340B hospital can profit from a prescription dispensed to an insured beneficiary. The hospital profits from the difference between the pharmacy's reimbursement minus the fees to the contract pharmacy and the 340B intermediary vendors and a drug's 340B acquisition cost to the hospital. In 2013, the Pharmacy and Therapeutics Journal reporter Stephen Bartlett cited that some hospitals have added millions of dollars to revenue to their bottom line by selling a large percentage of 340B drugs to private pay patients. It also reported Senator Grassley spotlighted 3 North Carolina hospitals for upselling: Duke University, UNC Chapel Hill, and Carolina Medical Center. Duke Hospital reportedly made $69.7 million in profit last year by upselling the discounted drugs to patients. The Office of the Inspector General reported in 2014 of the 15 disproportionate share hospitals interviewed in the report, only 1/3 reported to the Office of the Inspector General that they offer 340B discounted pricing to the uninsured patients and at least one of their contract pharmacy arrangements. Clearly, given the scrutiny of the integrity of the intent of the program, the unanticipated growth, the exploitation by the for-profit organizations, the program guidance of 2010 is under reconsiderations. Both the hospital's organization culture and leadership will have a significant impact on how the organization will act in this scenario. Given its financial stakes are high, the organization must carefully make decisions balancing ethics and revenue. Hospital leadership must look to the mission, vision, and values and demonstrate that their actions are aligned with the organization's principles. The values of integrity and honesty are important, but even more so in this highly visible controversy. Integrity is doing the business the right way. The leadership's action can help the organization demonstrate honesty and commitment to patient care by aligning their goals with the intent of the 340B program to provide resources to the indigent patient population. Referring to the American College of Healthcare Executives, ethical decision-making is required by the healthcare executive, must address a conflict or an uncertainty regarding competing values. In this case, organization, professional, and societal values are at stake. As a leader, my action would need to be ethical and aligned with my organization's values. While every healthcare organization faces financial pressure in the current climate, I would demonstrate ethical leadership by accessing the 340B program as intended to support indigent patient population and not solely for revenue generation. I would support our organization to limit the number of contract pharmacies where it is demographically and geographically appropriate. Our organization would only have contract pharmacies where indigent patient care has been identified as a need. Another key component is to make sure that discount 340B price are offered to uninsured patients through our contract pharmacies. There are a number of risk points with this program, and I would support having allocated resources and ongoing monitoring of the program to ensure regulatory compliance. The competing values are quite profound in this case, not only within the organization, but also between the hospital and the retail pharmacy chains. The hospital and its leadership is focused on control, patient care, quality, compliance, while the retail pharmacy chain is motivated by competing for revenue opportunities and profits. It is a clash of non-for-profit hospital's values of commitment to quality patient care against a for-profit company that likes to maximize profits and its commitment to shareholder earnings. We hardly find any of their values and principles are aligned. Now let's turn our attention to the Affordable Care Act, another hotly debated topic in healthcare today. The Affordable Care Act has created challenges to both hospital organizations in healthcare and as well as healthcare providers. This will challenge how organization providers make certain decisions on patient access, therapies while maintaining quality, efficiency, and balancing the reduction in reimbursement. Some organizations made adjustments by reducing professional care staff to patient ratio by hiring technical level staff to drive down the cost of labor, while others implement creative billing practices. The Affordable Care Act will generate a large number of newly insured patients, flooding the current delivery system that is already fragile and strained. Heiser in 2013 Congressional Research Service report on physician supply and Affordable Care Act reported that the Affordable Care Act newly insured population is expected to require 8,000 additional primary care physicians. The problem is further compounded by both an aging workforce and an American population that will require more healthcare resources. Heiser in 2013 Congressional Service report on physician supply and Affordable Care Act reported that estimated 2.8 million registered nurses and about 985,000 physicians currently working, about one-third will likely retire in the next decade. In November 2013, the Federal Interagency Forum on Aging reported related statistics reported by 2030, 72 million Americans will be 65 and older, a 50% shift in age demographics since 2000. since the year 2000. Many of the hospitals have already implemented patient care techs to assist nurses, but at the same time allow nurses to take on a heavier patient load. However, according to the 2007 Agency on Health and Research Quality Report, Nursing Care Quality of Patient Care by Kane-ETL reported lower nursing staffing ratios and higher nurse-to-patient ratio. Lower staff nurse levels and higher nurse-to-patient ratios have shown to increase mortality and morbidity. In October 2014, Modern Healthcare, reported by Lisa Schreck, reported Riverside Hospital in Texas attempted to defraud Medicare of $158 million for mental health services that were medically unnecessary or never actually provided. Between 2005 and 2012, Riverside and its satellite locations billed Medicare for partial hospitalization program services for Medicare beneficiaries who did not qualify for these or needed these services. According to the Wall Street Journal, reported by John Carreyrou on April 30, 2015, 9 hospitals in Jacksonville, Florida area, and a local insurance company agreed to pay a total of $7.5 million to settle civil allegations that they defrauded Medicare with ambulance rides that were medically unnecessary. The impact of Affordable Care Act will pose both financial and resource challenges to hospitals. While there are difficult decisions to make, organization culture and leadership is critical in arriving at ethical decisions. Healthcare executives are embodied with trust to make sure ethical decisions related to issues of access, affordability, pressure to reduce costs, finance, and resource constraints. Team collaboration and transparency with staff is vital to ensure safe patient practices. As a leader, I would recommend using evidence-based research results to establish accountable, acceptable staffing ratios. Another potential solution is to encourage and challenge all healthcare disciplines to practice at the top of their license. In some areas, provide staff with adequate training programs and competencies to allow them to be successful in their new roles. This can't be accomplished through additional certifications, internships, or residencies. Leadership must remain focused and true to their priority and commitment, which is patient care. Honesty and integrity are critical values of an organization's compliance. Even under financial pressure, ethical decision-making will protect the organization from unnecessary risk. As a trusted healthcare leader, I must demonstrate accountability, integrity, and honesty in making ethical decisions. The benevolence of doing good and avoid evil must be present at all times.